Hello everyone and welcome to our module on other gram-negative bacteria. This is the algorithm for identification of gram-negative bacteria, and in another module I talked about all the gram-negative rods. So in this module what I'm going to do is talk about the gram-negative cocci, the coccobacilli, and then finally we'll talk about Campylobacter and Vibrio, which are unique comma-shaped organisms. The first bacteria I want to discuss is one that's not on the slide I just showed you, and that's Moraxella catarrhalis. This is a gram-negative diplococci, just like Neisseria, and it's a colonizer of the airways. And in fact, it used to be believed that it didn't cause disease, but it's now believed that it is a factor in many infections of otitis media, which are inner ear infections common in children, and it's also a bacteria involved in some COPD exacerbations. It's usually treated empirically without microdiagnosis, and it's covered by most of the antibiotics that are used for COPD exacerbations and otitis media. And the reason it's not on the previous slide is because it's not part of most microbiology lab algorithms. Most labs will not speciate airway samples that have gram-negative cocci. So for example, if you send a sputum sample to the lab and it shows gram-negative cocci, the lab often won't speciate it any further than that. And that's because Moraxella catarrhalis is a normal airway colonizer, and in addition, there are non-virulent strains of Neisseria that are also normal airway flora. So that's why it doesn't usually appear on algorithms for identification of gram-negative bacteria. The only thing you really need to know about this bug is that it's a colonizer of the airway and that it's involved in some ear and respiratory infections. Now let's talk about Neisseria, which is a very important bacteria. There are two medically important species of Neisseria, meningitis and gonorrhea. They're both gram-negative cocci that occur in pairs, often described as diplococci. They both ferment glucose, but meningococcus can also ferment maltose, whereas gonococcus ferments only glucose. And you can remember this by the first letter of the name. So meningococcus can ferment maltose and gonococcus can ferment only glucose. And this is the way they're distinguished from one another, by whether or not they're able to ferment and grow on maltose agar. Both produce IgA protease as a virulence factor. And one thing that's very high yield to remember is that ceftriaxone, which is a third-generation cephalosporin, is often used to treat both. Neisseria meningitidis causes meningitis and meningococcemia, which is a bloodstream infection with this bug, and it's easy to remember it causes meningitis because that's in the name. It's transmitted by respiratory droplets, so if someone has a virulent strain of meningitis in their mouth, they can breathe that out in respiratory droplets and infect someone else. When Neisseria enters your body, it enters the pharynx, and then it goes to the bloodstream, and then it goes to the CSF, which is how you get meningitis. And there are many asymptomatic carriers. There are strains of this bacteria that don't cause disease, and many people carry this around. It's commonly detected in sputum samples, but if you acquire a virulent strain, you can then get sick. Virulent strains of meningitis have a polysaccharide capsule that prevents phagocytosis. This is a very important virulence factor. One thing that's unique about their outer membrane is that they have what's called lipooligosaccharides, or LOS. This is an endotoxin. It's just like the LPS present on gram-negative rods, but it has a little bit different structure. It's smaller and it lacks the O antigen, but nevertheless it does the same thing, same toxic effects as lipopolysaccharides and exotoxin, and it activates a severe inflammatory response. And I talk about exotoxin in more detail in the module on virulence. There is a vaccine available for Neisseria meningitidis, and this contains capsular polysaccharides, which then cause an immune response and have you generate anti-capsular antibodies that protect you from infection. Patients who get meningitis from this bug can get bacteremia complicating the meningitis, and this is called meningococcemia. It's a very life-threatening and severe illness. People will have symptoms of sepsis, like fevers, chills, and tachycardia. They often get a purpuric rash, so someone who has meningitis and then develops a rash, it's very concerning that the bacteria has gotten into the bloodstream. There's a high frequency of developing disseminated intravascular coagulation. Patients with meningococcemia can develop the Waterhouse-Friedrichsen syndrome. This is where they have adrenal destruction of meningococcemia. So when your adrenal glands get destroyed, you will lose your cortisol levels and you will become hypotensive and have other symptoms of low cortisol levels. And as I said before, it is life-threatening to have meningococcus in the bloodstream. Meningitis often causes outbreaks, especially in places where people live in close quarters, like college dorms and barracks. So one person acquires a virulent strain and then they can pass it around in their respiratory droplets. Another thing that's scary about this bacteria is that it can affect young, healthy people. So college students in dorms can get this and potentially die from it. Every once in a while you read a story in the paper that a college student died from meningitis, and that's Neisseria. Infected patients need to have droplet precautions, so they usually wear a mask so that they can't spread this around. And close contacts, for example, the roommate of a person in college who has meningitis, need to get prophylaxis and a vaccine. The prophylaxis is usually rifampin, but sometimes ceftriaxone or ciprofloxacin is used. A lot of people like ciprofloxacin because it's generally very well tolerated. And then, of course, close contacts need to be vaccinated as well. Very rarely, children are born with deficiencies in one of the terminal components of the complement pathway, and children who are born with a deficiency like this will have recurrent Neisseria meningitis infections. So recall that there are two pathways by which the complement system can be activated. The first is called the classical pathway, and this pathway depends on antibodies as is shown in this picture. The second pathway is called the alternative pathway, and this does not depend on antibodies. But both of these pathways lead to formation of something called the membrane attack complex, and this pokes holes in bacterial cell walls and causes bacterial cell death. And the membrane attack complex is made up of C5, C6, C7, C8, and C9. So if a child is born with a deficiency in C5 through C9, they have what's called a terminal complement deficiency, and they will develop recurrent Neisseria meningitis infections. You really need the membrane attack complex and the complement system in order to defend against encapsulated bacteria, and in particular, you need it to defend against Neisseria. So children who are deficient in C5 through C9 will have recurrent Neisseria infections. Usually it's meningitis. And in a board question, this is going to be a child who gets several bouts of Neisseria meningitis infection, and you should think that they have a deficiency in one of these components of the complement system. So now let's talk about the other Neisseria species, and that's Neisseria gonorrhea, and this mainly causes gonorrhea, which is a sexually transmitted disease. You should know, however, that it can cause many other conditions besides gonorrhea. We're going to talk about all of these in this module, but these include pelvic inflammatory disease, septic arthritis, conjunctivitis in newborn babies, and something called the Fitzhugh-Curtis syndrome. A very important feature of gonorrhea, and something that is high yield to know for step 1, is that the bacteria has antigenic variation of its pilus proteins. This means that subsequent generations of the bacteria vary the proteins present in their pilus, so you don't get long-term immunity after infection. If you've had gonorrhea once, you're still vulnerable to get it again. The first infection does not protect you, so reinfection is likely impossible. This also means you can't make a vaccine, because if you vaccinated against one species, the next species would be different and you wouldn't be protected. Most men and women with Neisseria gonorrhea infection are asymptomatic, and this is one of the reasons it's easy for this infection to spread as a sexually transmitted disease. You should also know that Neisseria gonorrhea and chlamydia, which we'll talk about in a minute, often co-infect. They are both sexually transmitted infections, and they can both cause the same symptoms. So anytime a diagnosis of gonorrhea is made, testing is usually done for chlamydia as well. In men, gonorrhea can cause urethritis. This presents as dysuria and discharge from the penis. It can also progress to epididymitis or orchitis, which is inflammation of the testes. In women, gonorrhea causes cervicitis. This usually presents with itching and discharge from the cervix. It's usually not painful, but it can progress to a painful condition called pelvic inflammatory disease. So let's talk about pelvic inflammatory disease now. This is when the infection with gonorrhea ascends and infects the uterus or the ducts or the ovaries. Women who have this condition present with pelvic and abdominal pain. They'll often present with painful intercourse. That's called dyspareunia. And a classic finding on physical exam is cervical motion tenderness. So when you move the cervix, it's very painful. This is classically called the chandelier sign because it's so painful that women jump off the table and hit the chandelier. And once you've had pelvic inflammatory disease, there's a very high risk for subsequent ectopic pregnancies or infertility. So if you see a young woman who's infertile, one thing you should think of is that she may have previously had gonorrhea. Same thing if you see a woman who has an ectopic pregnancy, she may have previously had a gonorrhea infection that clogged up her ovarian ducts and caused her to have an ectopic pregnancy. Another complication you can get from gonorrhea is something called the Fitzhugh-Curtis syndrome. So this is inflammation around the liver, and the way I remember this is I just think of that infection climbing up from the cervix to other parts of the pelvis. That gives PID, and it can climb even further all the way up to the liver. Fitzhugh-Curtis syndrome is inflammation of Glissen's capsule around the liver, and these women present with severe right upper quadrant tenderness, and they also have pleuritic pain. So when they take in a breath, they move the diaphragm against the liver, and it gives them pain. A classic finding in the OR is something called violin string adhesions of the parietal peritoneum. So when you pull the parietal perineum off the liver, you will see strings of adhesion like this that look like violin strings, and that's a finding consistent with Fitzhugh-Curtis syndrome. Gonorrhea can spread to joints and cause septic arthritis. This is a disseminated gonococcal infection. It complicates a few % of people who have gonorrhea, and it gives symptoms of septic arthritis. So the key scenario is going to be a sexually active young person who presents with a swollen, warm, and painful knee. They have gonorrhea that's gotten into their knee and they have septic arthritis. Women who have gonorrhea can pass it to their baby when the baby goes through the birth canal, and this will cause conjunctivitis. This is a condition called ophthalmia neonatorum. It's also caused by chlamydia, so either gonorrhea or chlamydia can do this. The baby will get swelling and discharge from the eye about 5 to 14 days after birth. And if this isn't treated, it can lead to visual impairment and even blindness. And hundreds of years ago, many babies went blind shortly after birth because their mothers were infected with these bacteria and passed it to them in the birth canal. Because of this possibility, all newborn babies in the labor and delivery room are given erythromycin ointment in their eyes so that just in case the mother had chlamydia or gonorrhea, the baby will be protected. And in fact, prophylaxis is mandated by many states because they don't want to see the babies go blind. Now let's talk about chlamydia, which can also cause sexually transmitted disease like gonorrhea and causes a number of similar illnesses to gonorrhea. Chlamydia are obligate intracellular organisms, and this is because they cannot make their own ATP. They have a unique cell wall that lacks muramic acid, and recall that N-acetylmuramic acid, or NAM, is a component of peptidoglycan. So the cell walls of chlamydia lack peptidoglycan. For both of these reasons here, this bacteria does not gram stain very well. It's technically called a gram-negative bacteria, but the stain that is often used for chlamydia is the Giemsa stain. And remember that the Giemsa stain was developed to identify Plasmodium, which is an intracellular protozoan, so it's very good for identifying intracellular structures, including intracellular bacteria like chlamydia. Because of chlamydia's unique structure, penicillins generally do not work well. In addition, ceftriaxone, which is a third-generation cephalosporin, which is used for gonorrhea infection like we talked about earlier, is also ineffective against chlamydia. So the treatment of choice for chlamydia is either azithromycin or doxycycline. Both of these antibiotics are protein synthesis inhibitors. Chlamydia has two phases to the life cycle. The first phase is called an alimentary body. These are small, dense structures that enter cells by endocytosis. The second phase is called a reticulate body. This is what replicates inside other cells by fission, and this is what you can see in tissue culture when you look at chlamydia under the microscope. Elementary bodies and reticular bodies grow and multiply, and then they eventually rupture inside cells in the human body and disperse, and this is how the bacteria makes you sick. There are 3 chlamydia bacteria that you need to know about. The first one is Chlamydia trachomatis, and this is the sexually transmitted bacteria that most people think of when they hear the name chlamydia. This can cause urethritis. It's called non-gonococcal urethritis, obviously, because it's not caused by gonorrhea, and it can also cause PID and conjunctivitis and something called reactive arthritis. We'll talk about all these things in the next few slides. There's a second chlamydia you need to know about called Chlamydia pneumonia. This can cause atypical pneumonia, and it's transmitted by aerosol. And I talk about this in the pulmonary modules on pneumonia. And then finally, there's a bacteria called Chlamydiophilus psittaci. This causes psittacosis or parrot fever. This is a zoonotic infection transmitted from birds to humans, and I talk about this in the module on zoonotic infections. So let's focus in on Chlamydia trachomatis. This is sexually transmitted just like gonorrhea, and also just like gonorrhea, many patients who have this are asymptomatic, including men and women. Women who get symptoms get cervicitis, just like gonorrhea, so they'll have discharge, they may have postcoital bleeding, and it can progress to pelvic inflammatory disease and Fitzhugh-Curtis disease, just like gonorrhea. Men who have symptoms have discharge and dysuria, also similar to gonorrhea, but the thing to remember here is that the treatment is different from gonorrhea. The antibiotics of choice here are azithromycin and doxycycline. Newborn babies can get chlamydia from passage through the birth canal, just like gonorrhea, and this will give them conjunctivitis, just like gonorrhea, and this is why that erythromycin ointment is placed in the eye of all newborn babies. One unique thing that chlamydia can cause in a baby that gonorrhea does not cause is pneumonia. This occurs when the baby is a few weeks to a few months old, and it has a classic feature that you should know for your boards, and that's the staccato cough. So the baby will inspire and take in a breath between each single cough. And most of these babies will have a history of conjunctivitis from chlamydia as well. If you want to test a woman or a man for infection with chlamydia, the test of choice is called a nucleic acid amplification test. This is a PCR of the chlamydia DNA and RNA, and this is the gold standard for identifying infections. Culture and staining are not done routinely anymore. Remember that the Giemsa stain is very useful for chlamydia, and you can see chlamydial inclusion bodies in the cytoplasm of epithelial cells sometimes under the microscope. Chlamydia can trigger a reactive arthritis, and this is an autoimmune arthritis. So this is very different from gonococcal arthritis, where the bacteria spreads to a joint and causes an inflamed, swollen joint. In this case, the chlamydia triggers an autoimmune reaction, and this leads to arthritis. Reactive arthritis can occur from a couple of different kinds of infection. Many enteric bugs can do this, like Salmonella, Shigella, Campylobacter, Yersinia, even C. difficile, but chlamydia can also do it. Sometimes the reactive arthritis occurs as part of a classic triad called Reiter's syndrome. This is where patients develop arthritis in addition to conjunctivitis and urethritis. So when you see these three things together in someone who recently had either a GI infection or an STD, then what they are having is an autoimmune reaction to the infection. It's usually diagnosed just by classic features following a typical infection, and it's treated with nonsteroidal anti-inflammatory drugs. Lymphogranulomum venereum is a chlamydia infection that enters the lymphatics, and it's caused by different serotypes of chlamydia from those that cause urethritis. It's very important you understand what this statement means. It means that patients who get urethritis are not going to get this condition. And conversely, people who get lymphogranulomum venereum are not going to get urethritis. They are caused by different serotypes of the bacteria. This is sexually transmitted just like other chlamydia infections. Initially, patients develop a genital ulcer, but this is sometimes unnoticed and then it resolves. Later, the bacteria enters the lymph nodes, and what usually brings patients to medical attention is the presence of tender inguinal or femoral lymph nodes. If you look at this picture here, this man has swollen and red lymph nodes in the groin here, and this is going to be very painful, and this is going to bring him to see his doctor to get medical attention. These lymph nodes are sometimes called buboes, and the treatment is to drain the buboes or the lymph nodes and to administer antibiotics. Now, I told you before that chlamydia can cause conjunctivitis in newborn babies, but it can also cause another eye condition called trachoma. This is caused by unique serotypes of chlamydia, so different serotypes from the ones that cause urethritis and lymphogranuloma. This occurs mostly in Africa and developing parts of the world, and these chlamydia serotypes are highly contagious. They're spread by contact with eye secretions. Acutely, they cause conjunctivitis, but if you get repeatedly infected, you can get scarring of your cornea and go blind, and it's a leading cause of blindness worldwide. I've listed on this slide the serotypes of chlamydia and the infections they cause. So serotypes A, B, and C cause trachoma or blindness. They're found in Africa. You can just remember the A is for Africa. Serotypes L1, L2, and L3 cause lymphogranuloma, and that's easy because they all start with L. And then the remaining serotypes D through K cause the symptoms we think about with STDs due to chlamydia, so urethritis and PID and the neonatal infections. So going back to our algorithm for gram-negative bacteria, I've discussed the gram-negative diplococci as well as chlamydia, and what I'm going to do now is talk about these comma-shaped organisms up here, which include Campylobacter and Vibrio. Campylobacter includes Campylobacter jejuni and sometimes Campylobacter coli, and these are faint gram-negative bacteria. The gram stain's not very sensitive because sometimes they do not gram stain. They are spiral-shaped and curved rods. They're described as comma-shaped. This is a picture of some of them highly magnified under the microscope here, and you can see that they've got this funny twisted shape. They are oxidase positive by the oxidase test, and they have a feature called microaerophilic. This means they require oxygen, but they actually live best in places where there are low oxygen levels. There are two very high-yield things to know about Campylobacter. The first is that it's a very common cause of acute diarrhea, especially in children. It's actually a leading cause of acute diarrhea worldwide. It's transmitted fecal-orally, and in general, things that are transmitted fecal-orally are often common in children because they just tend to have dirtier hands and touch more things than adults do. It lives in the intestines of animals, especially poultry. You can get it from eating undercooked meat like poultry or from consuming unpasteurized milk. You can also get it from drinking contaminated drinking water. The second high-yield thing to know about Campylobacter is that it's a common trigger of the Guillain-Barré syndrome. This is a demyelinating disease with ascending weakness, and I talk about this in the neurology modules, but the thing to remember is that you will often see a GI infection preceding the onset of Guillain-Barré, and the bacteria that likely caused that GI infection was Campylobacter. There are a couple of Vibrio you need to know about, but the most important one is Vibrio cholera, which causes the disease cholera. It's a toxin-mediated disease caused by the cholera toxin, And one thing that's high yield to remember is that cholera toxin is one of those toxins that has its genetics carried by a lysogenic bacteriophage. This toxin permanently activates the G protein, increasing the cyclic AMP in cells, and this leads to voluminous rice water diarrhea. And I talk about all this in more detail in the module on virulence factors. It takes a large dose of cholera bacteria to make you sick, and that's because the acid in the stomach kills small numbers of bacteria. So cholera is common in areas that lack clean water, where people consume large volumes of contaminated water and they overwhelm the ability of the stomach acid to kill the bugs. It's also more likely to occur in people who take acid suppression medications. These lower the dose of cholera required to make you sick. People who get cholera have death from dehydration and electrolyte losses, so the mainstay of treating cholera is to replete the volume aggressively until they overcome the infection. There are two other Vibrio you should know about, and those are Vibrio vulnificus and Vibrio parahemolyticus. These are both relatively minor pathogens. They both can cause food poisoning and diarrhea, classically from consumption of raw oysters. And then Vibrio vulnificus can also infect wounds after swimming in contaminated water. So back to our gram-negative algorithm. So now we've talked about the Neisseria, we've talked about these bacteria up here. So what I'm going to finish this module out with is a discussion of the coccobacilli right here. Now, Pasteurella and Brucella are zoonotic diseases transmitted from animals to humans, and I discussed these in the module on zoonotic infections. So we'll finish up here by talking about Haemophilus, Bordetella, and Yersinia. Haemophilus influenza is a gram-negative bacteria that colonizes the nasopharynx, and it causes several respiratory diseases, and it can also cause meningitis. Some Haemophilus have a polysaccharide capsule, some do not. The ones that have a polysaccharide capsule are called capsular, and they are typable into 6 serotypes labeled A through F. The others are called non-typable, and we'll talk about this in a minute, but they cause different illnesses. Most of the serious and life-threatening disease is caused by H. flu type B. This contains a capsule with substances called ribosol and ribitol phosphate in a polymer. The vaccine that children get contains the type B capsule. It's called the HIB or HIB vaccine. It contains the type B capsule conjugated to a carrier protein that is usually tetanus toxoid. By conjugating it, you get a stronger T-cell response, and this is given to small children usually before 7 months of age. Special features of Haemophilus influenza to know about are that it uses IgA protease as a virulence factor. In addition, it grows on a unique type of agar called chocolate agar. This is modified blood agar that contains factors 5 and 10, and I talk about this in more detail in the module on culture. Haemophilus influenza will also grow on blood agar when Staph aureus is present. That's because Staph aureus is beta hemolytic, and it lyses the red blood cells and spills factors 5 and 10 into the blood agar so that H. flu can grow. One of the most dangerous infections that H. flu causes is epiglottitis in children. This is a life-threatening inflammation of the epiglottis that can cause airway obstruction and death. In a board question, this is going to occur in an unvaccinated child who has fever and sore throat and then develops difficulty swallowing, that's dysphagia, and often drooling. And if you look in the throat with a scope, you will see that the epiglottis appears cherry red. That is a classic finding of epiglottitis. H. flu can also cause pneumonia, and it can also cause meningitis, and the vaccine generally protects against these illnesses. H. flu can also cause otitis media and bronchitis and sometimes conjunctivitis. These things are more often caused by strep pneumonia, but they can be caused by the non-typable H. flu. And because they're caused by the non-typable H. flu, this means that the vaccine is not protective against this. So an important thing to know is that children who have received the H. flu vaccine can still get otitis media from H. flu because it's a different variant of the bacteria. There's another Haemophilus, and this is Haemophilus ducreyi, and this causes chancroid, which is a sexually transmitted disease. It gives you a painful genital ulcer. And contrast this with the chancre caused by syphilis, which is a non-painful genital ulcer. As I said before, it's sexually transmitted, and it's resistant to many penicillins. The treatment for this is azithromycin or ceftriaxone. So this is a good point to pause and review the multiple causes of genital ulcers. So syphilis causes a painless chancre. And remember, this often goes unnoticed because it doesn't hurt and patients progress to the second stage of disease. Ducreyi causes the painful chancroid, which is a painful ulcer. Herpes can cause multiple vesicles and ulcers, so it'll look very different from the single ulcer that you'll see with these two conditions. And then finally, lymphogranulomum causes these large swollen lymph nodes, which are called buboes, and they're very easy to distinguish from the ulcers of these other conditions here. The next bacteria is Bordetella, which causes whooping cough, and whooping cough is very rare in the modern era because of vaccination. People who develop whooping cough will have typical upper respiratory infections, so they'll appear to just have a cold, but what will be unique is the severe coughing, which has a classic presentation. There will be paroxysms of coughing, so long spells of coughing, followed by an inspiratory whoop and then often post-cough vomiting, and patients with this condition get exhausted from all the coughing. The coughing can last for weeks. In fact, in China, pertussis is known as the 100-day cough. Bordetella is transmitted by aerosolized droplets, and it has an important toxin called pertussis toxin. I talk about this in the module on virulence. This toxin inhibits G-inhibitory proteins so that you get overactivation of adenylate cyclase. This increases the cyclic AMP levels in neutrophils, and the result is impaired recruitment of neutrophils. One interesting fact is that the toxin may not be the cause of the cough, because some bacteria that lack the toxin still cause the cough symptoms. As I said before, infection is rare in the modern era due to vaccination. The vaccine is called an acellular pertussis vaccine. It contains purified antigens from the bacteria. The final bacteria I'll discuss is Yersinia enterocolitica, and this is a bacteria that's found in domesticated animals, especially dogs, but also pigs. You get it through consumption of contaminated foods, usually contaminated pork or contaminated water or milk. Causes a bloody diarrhea in addition to other symptoms like fever and abdominal pain and nausea and vomiting. One very high yield thing to know about this bacteria is that it causes something called mesenteric adenitis. This is inflammation around the appendix or in the mesenteric lymph nodes. This can mimic Crohn's disease or appendicitis. So in a board question, they may describe a patient who appears to have appendicitis, goes to the operating room, and the appendix is entirely normal. They likely had an infection with Yersinia enterocolitica. And don't confuse this with the other Yersinia, Yersinia pestis. This causes the plague, and I discussed this in the module on zoonotic bacteria. And that concludes our module on other gram negatives.